I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Natalie Ferguson, Assistant Director of Nursing at SUNY Downstate Medical Center. She's here to talk about the importance of culturally congruent care and patient outcomes. Thanks for speaking with me today, Natalie.
Thank you so much for having me, Tamara. I really do appreciate it.
It's a pleasure to have you. All right, so let's get started. Please talk about your background and your work for SUNY Downstate Medical Center.
So a little bit about my background. I've always, it's always been one of, of service. I came to this country about over 30 something years ago, and I've always worked as a babysitter, housekeeper. So I've always been in service to others. So it was a natural progression for me to go to college, get my nursing degree, and I started working at Downstate as a nursing assistant and working my way up to now presently as a ADN in the Cancer Center and community outreach. And what I do there is I'm sort of a liaison for the cancer patients in regards to medical as well as nursing services, financial resources, and really working with the physicians just to ensure continuity of care in their treatment. And one good thing about this ADN position is that I'm also able to provide not only that sort of nursing support, but also emotional as well as any supportive care um, that they may need.
Wow. So what exactly is culturally congruent care and how important is it to patient outcomes?
Well, I'm so glad to be discussing this topic because it actually is a new ANA, which stands for the American Nursing Association. It's the standard number 8. It's a new sort of standard of care that we're implementing. So I'm really, really happy about that we're talking about this. So culturally congruent care it's really based on evidence-based nursing, which is very important to me because as an advanced practice nurse, uh, I really am very, very passionate about anything that deals with evidence based, because as you know, evidence-based nursing is the backbone from Florence Nightingale and what we do. So evidence-based practice, evidence-based care, congruent care is sort of where there is an agreement with the preferred cultural values and beliefs and practices of the consumer. Whereas nurses, we are able to demonstrate uh, working the understanding of the patient from their own cultural perspective. And it's very important that for patient for the patient outcomes, in the fact that you have to be able to build a really good provider-patient relationship. If you don't have a good provider-patient relationship, there's no way that you can get any sort of positive outcome from that patient. And the one way that you have to get that sort of relationship is understanding the culture of the patient, their history, where do they come from? Brooklyn is a melting pot of, of different cultures, uh, Caribbean, Jewish, um, American, Ukrainian, Russian, all different types of cultures. And how do we meld that and bring that together in order to understand where the patient is coming from? And that is where culturally congruent care comes in, looking at the patient, understanding how their culture affects how they look at their treatment, and working on that in order to build the best care possible and treatment for that patient.
Can you talk about the health impact of not having access to culturally congruent care? What have you seen happen to patients without it?
Okay, so most of the patients, if if they feel a disconnect with the doctor because they feel that the doctor is really not understanding where they're coming from, you're going to really get patient dissatisfaction. And patient dissatisfaction is really very hard to get the patient to work with you, because if they're not satisfied with their treatment, they're not going to come back. And that causes a higher risk for having negative, we call it negative health consequences, and also receiving poor patient care. Negative health consequences is the fact that a lot of, in Brooklyn at SUNY Downstate, for example, we have a high population of Caribbean American patients, for example.
Mhm.
And in the African American community, we have a high incidence of high blood pressure, of diabetes, and of sickle cell, of obesity. And all of these really are higher in the African American population and Caribbean population than any other population out there. And if we don't get these patients in to the hospital for the proper treatment, then it just, it's going to shorten their lifestyle. It's going to shorten their lifespan. It's going to, it's going to disrupt families and relationships, and cost not only the patient but the community as whole, and whole in the long run. Um, a lot, both financial and emotional. Then also, you have receiving poor quality of care as well, because a lot of minorities have, sadly, lower, what we call lower levels of health literacy. That means that their ability to understand and follow instructions for treatment sometimes can be limited, because sometimes they don't, English is not their first language. The Haitian community, for example, they do a lot of nodding, and you think that that nodding means that they understand, but the nodding in the Asian community is just a sort of as a sign of respect. So that's where understanding the differences in the culture of the different races that you are dealing with comes into play, because then you can treat the patient with respect, and you can get them to come into the doctor's office to get the treatment that they deserve.
I'm curious. So when you have this disconnect, I'm assuming you would get things like lack of compliance, right?
Yes.
And then you talked about, which was very interesting, like the Haitians just nodding, and it doesn't equate to understanding. It's just respect. How do you get patients like that back on track?
Well, the first thing that you have to do is really, you really have to understand, and this is where cultural congruent care comes in. You have to understand the culture of the patient. You have to understand, and what their culture entails about medicine. Where in the line does medicine come in, and work hand in hand? We call it, provider patient centered care, where, providers are no longer, how should I put it, for want of a better word, just issuing directions. Okay, you're going to do this and do that, and this is the step, but really working with the patients in order to get them to be an active participant in their care. That's the only way we're going to get these patients back. Understanding their culture, realizing, for example, some women in the Muslim communities, that their head wrap is very important for them. Having a female provider is very important for them. Having their husband there during the examination is important. So really being mindful and respectful of their their cultural beliefs, not negating it as something that is superficial and not important, but really understanding and looking at our own biases as providers and realizing, do I have some biases towards that? And really working on ourselves as doctors and nurses and nurse practitioners to see, where do we fall short? How do we need, what do we need to do to to work with this patient? What does this patient need from us? How do I bridge that gap? And sometimes it's just a matter of really speaking with the patient and asking them, how do you feel about this? Tell me, what are your concerns? How are you looking at this? And then once you're able to assess where their level of understanding is in their disease process, then you can incorporate their culture and their different beliefs and sort of mesh it together in order to get a treatment plan that works, and that you can have the patient come back into your facility and hopefully have a positive result.
So, what sorts of ways do you engage patients that's different from how providers of a different culture engage patients?
Well, usually I do a cultural assessment. Um, I sit down with the patient and I assess their cultural values. Nurses, we always assess our patients as well as doctors. Always assess, assess, assess. I remember that in nursing school, and it stuck with me. So you do something what's called a cultural assessment, where you find out from the patient, what are their preferences, what are their choices, how do they make decisions, sometimes how do they view their disease, how do they think, what do they think about what is happening and the reason why. Sometimes you would be surprised, they would think that it is it's a punishment of sort. So you have to find out exactly, and this is called a cultural assessment, and it's actually one of the ANA goals, because I'm also big on research. It's one of the ANA guidelines that we have to follow. I also do a lot of uh, personal, professional development, where I do a lot of research and I practice that. I pass along that research onto the patient into their different disease process. So, um, for example, sometimes where the cultural assessment is concerned, you have to know, okay, what challenges are the patient, um, what challenges are the patients experiencing in order that is deterring them from getting treatment or following up on treatment. You have to, also what I do is something called culturally congruent communication, where you have to speak in an effective and respectful manner. And it also involves listening to the patients, listening to their concerns, asking them again, how, well, what do you feel? How do you think? Sometimes a lot of providers may not really go into that because, we know what the patient needs to do in order to get better. But if the patient isn't at that level yet, then they're not going to follow through on their treatment. So
Mm.
we have to really mesh it together, and communication is so important. Using our tools to find out and engage the patients in in their care. Also, I utilize a lot of translations and interpreters. Sometimes there is a language barrier, and they would answer yes, yes, because English is not their first language. So they're saying yes, and you're thinking they're understanding, but sometimes yes is the only word that they know in English, really. So you have to, and you get that through your cultural assessment. Sometimes patients have hearing impairments.
Mhm.
So you have to also, navigate the sign language that we have here, um, as well. Sometimes they also have, you have like cultural appropriateness, and that would entail some of where the females, for the Muslim females, uh, you have to be very mindful because they don't like to take their clothes off. And sometimes, if you have to do an examination, especially if you have to examine their breast and, different areas, you,
Mhm.
you have to be very mindful of touching and letting them know, okay, this is the reason I have to do this. And this is the reason why, and explain it to them in their language. There's been a lot of research that has stated that providers, the language that we use, the terminologies that we use for each other, if we tend to use that on the patients really don't like that. They feel very uncomfortable, and it gives it gives the patient leaves with a bad impression of the physicians, a sort of a disconnect, because we're speaking in medical jargon, as they put it, and they don't understand that. So if you do your cultural assessment, then you can also do your educational assessment and find out where is that patient academically. A point of transparency: I have a son who is autistic with mild intellectual delay, and so therefore when he goes to his doctor, I really love how his doctor communicates with him, simplifies everything. He would ask me, as his mother, what works for your son? I think that is very, very important. I told him my son, for example, I'm just giving an example, is, he is a very visual learner, and you have to speak with him at a fifth grade level, educational level. And he did that. And my son was very happy. He understood everything. He was able to give the appropriate responses. And he came, my son became a part of the care at the level that he was at. And it made me, as the parent, also feel a sense of warmth and gratitude. And okay, I will deal with this physician again because of the way and the interaction that he interacted with my son, which is what we should all do with all of our patients, assessing, asking the patient what works for you and incorporating that and meshing it together.
I want to dig into this, and I wanted to talk about the health literacy. So you mentioned that you find with some patients low levels of health literacy. So where in these models that you put forth, which are wonderful models, by the way, how do you figure out that a person has low health literacy, and then how do you combat that?
So yeah, so the health literacy, like I said, it's the individual's capacity to understand and comprehend basic health information in order to make appropriate health decisions. And in order to have a high level of health literacy, they need to be able to understand what the disease is, what the disease process is, how it affects them, and the treatment modalities that is needed, and how that is worked is through cultural cultural assessment, effective communication skills, and working with the provider, working with the patient in order to educate them as much as to their level of capability, which also involves a sort of a educational assessment to see where your patient is at intellectually, how much information they can process, what you need to say in order for them to understand. And it's not being disrespectful, it is just being mindful of, okay, where your patient is at and what information do they need. For example, if I go to the doctor, I really don't need as much information about the disease process as, say, my mother would, for example,
Right.
um, because she's not, a doctoral trained nurse practitioner. So she would need a little bit more information versus someone whose language is first language is not English may need a little bit more. Someone who is not college educated may need a little bit more than someone who is college educated, and also depending on the college education that they have. So there's a lot of factors that come into working out on the health literacy of a patient. And cultural assessment now is definitely coming into play, because you have to know how to communicate, what type of cultural differences and degrees that the patient needs in order for you to explain and to increase their health literacy about their disease, so then when they come to the clinic, they can become an active participant in their care.
Slightly unrelated mini story, if you'll indulge me for a second. So I had a doctor's appointment about 6 weeks ago, and the medical assistant, she set out all the forms and everything, and I asked her if I could read the forms, because I like to take in my information visually and then process it, because I'm not really good in a stress situation with people speaking to me and asking me to agree,
Mhm.
not agree, etc. So I asked if I could read the forms, and she says, well, no, you have to wait for the doctor to come in. I said, no, I don't want to wait for the doctor to come in. I want to read them now, so that when he asks me if I understand, I actually understand. I don't,
Exactly.
and she became a little huffy with me because it wasn't her process. She's used to everyone just kind of saying, okay, we'll do it your way. But I know how I need to take in information. So, like you have to be flexible in terms of like how you relate to people and people's different needs. So that was my little story.
I'm really glad that you mentioned that, because a lot of patients in that instance, the doctors, they get the forms and they just sign it. And I have had instances where patients with consent for a procedure even, and the doctor, and I'm looking at the patient and I can tell that this patient is not understanding, but they don't say
They're afraid to
anything.
say
They
anything.
they don't say anything. And that's where really being mindful of this patient's culture and the signs and the looks of what the patient is giving you really comes into play. Because even though you may get the signature and you do the procedure and it really worked well for the patient because that's what the patient needed, you've missed out on a great opportunity to really that's not manifesting good provider patient
Yeah.
relationship, where the patient is an active participant in their care, because the research shows that once you get that patient being an active participant, then the battle is halfway won, in terms that the patients will follow their medication treatment. They will keep coming back for their appointments. They'll keep you updated on any changes. And it just works out well. So, it was a really good thing that you spoke up and you said, no, this is what I would like to do. And it is quite within your right to do that, and be prepared to ask any questions of your doctor based on what you were reading for further clarification.
Well, thank you. Speaking of opportunities, I was talking to Annabelle Thompson Castro some weeks ago, and she talked about patients bringing friends or family with them to their visits. And she was saying that that's an opportunity that some providers miss out on because, some people sort of caucus with their friends and family to make medical decisions. What do you think about that?
Oh, I think it's a fantastic idea. A lot, some, you have some providers, every provider, likes and works differently. I think some providers, they don't, they don't like asking too much questions. I love it. I love it. I used to, when I was a staff nurse, I would, I'd make a joke of it. The families would come in because I know they're concerned. The
Mhm.
patient is in the heat of the moment and everything, and you're hearing all of this, and a lot of doctors and medical personnel. It can be very, very overwhelming. And once it's all gone, then culture again. I would see the patient just looking very confused. The daughter would come in, or the husband, and they would be like, well, mom, what happened? What did the doctor say? Oh, I don't know. I can't
Right.
remember what they said. I'm not sure. I don't know. Well, when you're supposed to, I don't know. I can't remember. And it so then the families get a little bit nervous, because then they want to know what's going on, because mom can't explain it. So I think once the family is there, I think it would give them an opportunity to ask any questions of the doctor that they want to. And I think I always would give my patients ample opportunity to ask me any question. Um, any question at all. What would you like to know? Um, and give them time to think about it. The brother, the mother, because the family unit is the one that's going to help this patient when they leave the hospital, if it's
Right.
after surgery or if it's a doctor's visit, especially if you have an elderly patient, or if you have
Right.
a patient like my son who is autistic. The family has to be the one that has to really follow through. So they should be a part of the discussion. And most cultures warrant it. A lot of, the granddaughter would come in and be talking for the grandmother. In the Muslim culture, the husband is there. So, it's good to have the family involved. The only thing I would say where I would have a problem, and the family cannot be involved, obviously, if you suspect any, like domestic violence or domestic abuse, then you have to get the patient by themselves, where you can ask them, well, what is going on, if it's a safe environment, that sort of thing. But that's a whole completely, different area. Medicine is not concrete.
Right.
There's always variations to the rule. So if you feel there's any sort of domestic, any type of abuse, elder abuse or whatever, of course, you want to get the patient away if you think the abuser is the one that's there. So of course that's a whole different scenario, I'm sure, for a different conversation. But um but in regular terms, with a caring family, I totally agree that the family should be there. And a lot of clinics and recovery rooms after surgery, they do allow in the recovery room the family to be there, because they know the patient is not at that time able, because of medication or the drugs, or just the fact of being hyper and getting news. If you're getting a cancer, news that you may have cancer or something, you
Right.
need
A
someone
diagnosis.
you need someone there, because that patient now has moved to an emotional state, and they're
Right.
not thinking logical for really good reason. So the person that's there with them then has to get all of that question, that once that patient goes home and the emotion is gone and she's starting to think a little bit logically about what the next steps are, at least that family member is there to sort of fill in the blanks of what she didn't get in her state of heightened stress at that
Can
time.
you talk about patient outcomes as a result of culturally congruent care? And what recommendations would you make to medical centers, if you could, to improve access to such care for diverse patient populations?
So the effect of really having a cultural care is the fact that you increase the major outcome, which I think encompasses everything, is the fact that you increase the patient provider interaction. That increases the communication. That increases the patient-centered care. So you encourage the patient to be compliant with their treatment. You encourage the patient to really be an active participant. And that's going to increase their health outcome, because once the patient is compliant, especially like certain diseases that you have, say like high blood pressure or diabetes, where you really need this patient to really be compliant, because for example, diabetics, you have to check your sugar, like every morning. You have to watch your diet and exercise. Or your dialysis patients, they have to monitor their food intake. They have to come in order for their dialysis, every 3 days. So once you are aware and you become a active participant with this patient, and they really like you and want to work with you. Oh, I love my doctor, best doctor ever. The doctor understands, is compassionate, understands me, really talks to me and listens to what I have to say, really would ask me, how am I feeling today? Do I have any questions or any concerns? And I say, well, doctor, can you talk to my daughter? Because I really don't understand. And they talk to the daughter, and the daughter understands. Of course, you have a patient for life, because some of these diseases are for life, unfortunately.
Right.
Diabetes, high blood pressure, sickle cell, which is a mainly a disease in the African American community. And a lot of these diseases are really high in the African American community. And we have the lowest health illiteracy rate, and the more disparities, health, social, educational disparities. These are all facts. This is not something that I'm just making up. These are documented research facts. So in order to really start to get the patients to increase their health outcomes, we need to be an active participant with them, to want, so that the patient will want to come into the hospital and be treated, because realistically speaking, sometimes these patients have to be in the hospital, especially if they're getting chemo treatments for cancer, or have to take certain high blood pressure and check their blood pressure medication. We need to rely on them to give us the information that we need in order to make good medical decisions for their care. Patients should be aware of that. They should be aware that, we're not standing on a pedestal here, giving you information and listen to me because I am the doctor. No, it's about working together, telling me your concerns, finding the information out if I don't, and in order for the outcome, which will be a happier life. To the second part of your questions, um, what I would do for, I think, the medical centers to improve access of care for these diverse patient population. First of all, I would definitely encourage a lot of training, promoting access to care, uh, getting uh, teaching the providers, the nurses, the younger generation about respecting the respect of the patient. There are a lot of courses now and classes, and I believe SUNY Downstate also offers that as well, where they we have to upgrade our academic qualifications by taking certain classes. That's how we keep up to date. It's going on, like when you go to certain venues and certain committees where you learn different, the latest development. Um, so I would definitely get the new nurses to get a training in cultural competencies. Also, we need to hire a lot of translators and interpreters. um, Sometimes something as simple as hiring a sign language interpreter, someone that is able to communicate in sign language. Sometimes it's something as simple as having the literature that explains the disease process in French Creole for our Haitian speaking patients, Spanish, in Chinese, having it available, having signs up in different languages. I would also have that as well. Uh, for me, doing a lot of research to evaluate and to assess and to monitor how these new guidelines from the ANA that we have now, implementing them, and if they're working, and also encouraging the healthcare providers and the nurses, and in effective communication skills. I'm really big on that. Um, just knowing how to talk to people, to communicate with people on their level in a kind and compassionate way, and in a caring tone, and your body language also. People pick up on your body language. If you sit down with your arms folded, and you're looking down, your patient is not going to be very, very receptive. So, being also mindful and looking inward at yourself. What biases do I have? Everything starts sometimes with self-evaluation, self-assessment. Well, what do I need? What do I need to be better at? Every day, as a nurse, at the end of the day, you go over, well, what could I have learned from this experience and interaction with my
Oh, that's
patient?
wonderful.
Yes, absolutely. I do that all the time. What could have I done better? What did I do good? What needed a little bit more work? Did I come off? Did I give off a good bite? Did they really understand and get? And then once you do that self-assessment and self-evaluation, then you can know what it is that you need, and let your administrator know, let the hospital know, advocate for that. Say, I really think we can do better in this area. I have some suggestions. What do you think? Do your part to encourage and improve and make accessibility to information for the patient something that they would want in the future.
So the classes you're referring to CE, right? Continuing education.
Yes. As nurses, we have to do as nurse practitioners, you have to do CMEs. As nurses, I think it is very, very important that you find courses and classes that you can go to that that gives you more information on the area of nursing that you are in, and also the different cultural sensitivity classes. Medicine is not, it's ever evolving. It's not something that just stops. It's not one of those careers where, okay, I'll never, okay, I got my nursing degree, I got my doctorate degree, that's it, I'm done. It's ever evolving. Blood pressure changes from, the latest guidelines change the blood pressure from one grade to another. You have to know these things, because then if you're not up to date on your nursing education, you're not giving the patient the best care. You're not. And it's the same way with being culturally congruent care. It's the exact same thing. Well, okay, I have a high population of Muslims. So let me find out, what is it about their culture? What do I need to know? How do I say address them when they come in? What sort of body language should I be looking for? The blind patients, that's also, you need to know how do you address and deal with the blind patient or the hearing impaired patient, by being, and also not seeming condescending, or because they are very independent patients, and you have to know, well, up to what level and what ability do they not need your help with in maneuvering or making decisions? And all of these we have to learn. No one knows all of this information. And that's where, getting information, going to courses and classes, and keeping your own professional development as a medical professional comes into play.
Dr. Natalie Ferguson, thank you so much for this conversation. Truly, this is such an overdue topic that I think is not getting enough attention in the medical circles. I mean, obviously it's getting attention in the nursing circles, but I think this needs to also branch out into the physician and specialist circles. I hope you'll come back and share more about SUNY's work in providing culturally competent care.
Well, thank you, so much. I really appreciate this opportunity. I thank you so much for having me. This was wonderful, and absolutely, I would love to come back again. Thank you so much.
Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.